Hello everyone. This week on TBPPM Features, we will be hearing about how Excellence Community Education Welfare Scheme, fondly called as ECEWS, implemented an active case finding initiative under the Wave 6 TB Reach project in five hard to reach states in Nigeria. In addition to overcoming the geographical barriers that already limited access for TB care, ECWS also adapted a few strategies to overcome the challenges posed by the COVID-19 pandemic. Joining us today is Dr. Valerie Obo, a public health specialist with vast experience in TB control. Having reached the peak of her career as a civil servant, she serves as a permanent secretary in her state government but is still actively involved in TB services and currently is the project coordinator of the ECWS TB Reach Wave 6 Scale Up Grant. Thank you so much for joining us today, Dr. Valerie. Could you give us a brief overview of the project?
Thank you very much for having me here. Our project is titled Innovative Active TB Case Finding Among Riverine and Hard to Reach Communities in Southern Nigeria. In January 2020, with the Stop TB Partnership TB Reach with 6 Scale Up Grant, and it is an extension of the project that we carried out with the Wave 6 TB grant in October 2018. So this is like a scale up. The overall goal of the project is to rapidly expand TB services to the underserved populations of the fishermen, the riverine, and the hard to reach communities in 15 basic management units, BMUs, or local government areas, that, like we call it, in 5 project states in Nigeria. These states include Akwa Ibom State, Bayelsa State, Cross River State, Delta State, and Imo State. The essence of this project was in response to the high TB risk that we see in these areas, which is as a result of the overcrowding that we see over there, the non-functional health facilities, and limited access to health care, including the high transportation, even where the health care is available, high transport costs to where the health facilities are. We also have a high prevalence of HIV/AIDS in these areas, poor coverage for BCG vaccination, as well as malnutrition. So in response to all this, the ACUs decided to put up a proposal to TB Reach for us to be able to find TB cases actively in these particular areas. And of course, we decided to use the private health providers, because you know that even though that the private health providers are the first contact to most community members, 2.5% of them, according to statistics of 2017, were involved in TB case finding and treatment. So this project decided to address that gap by using the private healthcare providers. From January 2020 to March 2020, we were able to carry out the pre-implementation phase, or what we call the pre-active TB case finding phase. Fortunately for us, the first COVID case was diagnosed in Nigeria on the 27th of February 2020. So we had a little time. We were able to carry out advocacy approaches, and we engaged stakeholders at the community level, at the policy levels, and the national TB program, the state TB program. They were all engaged so that we could secure a buy-in, program ownership, and program sustainability. So within this period, we were also able to identify, screen, interview, and recruit patent maternity leaders from the different communities, also to recruit community volunteers. We were able to recruit community pharmacists as well as contact tracers. And our project used 4 main types of active TB case finding intervention. And these included the targeted community outreaches, the house-to-house or tent-to-tent community screening. We had a single an indicator for the PMVs, community screening by PMVs in their patent medicine shops. We also had the household contact investigation. Prior to the initiation of active TB case finding, we also used the period of the pre-implementation to train all the frontline health providers on TB management, as well as accurate reporting and recording.
Okay.
Also, it is important to mention that our active TB case finding coincided with the time of lockdown and restriction of movements, because by April, Nigeria was seeing a lot of cases. So the Presidential Task Force and they released the guidelines, the NCDC guidelines, which ensured that there was limited movements and there was also lockdowns. However, we were able to overcome these challenges, which we are going to discuss later in the program. It's important that I also mention that the project has a project team at the headquarters. We also have a project team at the different states, and this team are the ones that are going out on supervision and monitoring of the projects, mentoring of our frontline health providers, and also responsible to brief the local health authorities quarterly and also the state TB programs quarterly on project results.
Okay. Yes, and you did mention that about the various challenges that you faced. Can you talk a little bit more about the challenges while implementing the project? Other than the COVID, did you face any other challenges while going through with the project, and how did you overcome them?
Okay, there were some, apart from COVID, which was the major issue for our implementation, there were other challenges that we faced, and these included the issue of stock out of TB medicines. So I don't know whether that was as a result of COVID. So most of our facilities ran out of medicines, and so diagnosed TB cases were not placed on treatment. So what we were able to do is to link up with the TB programs and support them to ensure that drugs were taken to the different facilities. We also faced a low turnout in community outreaches because of COVID, we were not able to carry out community outreach in the first quarter, that's April to June. But starting from July, when there was relaxation of movement, we were able to carry out community outreaches. But I think maybe the fear of COVID, the fear of gathering, made people not to come out for screening. And so what we tried to do was to bring in the issue of incentives, like we provided hematinics. Hematinics, I mean iron tablets, multivitamins, folic acid. These encourage people to come out, knowing that they were going to have something to go back home, and we were able to screen them. We also, during the project, have faced a lot of challenges with the high cost of transportation. The high cost of transportation. I think this has been contributed to by the COVID as well. And so the project has ensured that it channels funds from other sources to support the frontline health providers, especially the sputum transporters, to be able to move sputum to the gene expired sites. Another major problem that we faced was that of attrition of the PMVs. We faced a lot of attrition of PMVs. Apparently, we have other partners coming to the field where we work, which were not there before we started. And we discovered that their enablers are better than us in our budget. And so the PMVs decided to be part of those, part of other partners. So what we have done now is wherever we have gaps, we have been able to fill them up with others who are willing to support us. Of course, over here, in our terrain, our weather. So we had a lot of rains, in fact, extraordinary rains this season. And this became difficult for the healthcare providers, especially in areas where they have a lot of hard to reach communities.
Okay.
So what we did was to ask them to suspend activities when there are floods. We had a lot of flooding this year, to suspend activities. And then when there is a little gap in the weather, to double those activities that they were supposed to carry out.
Okay.
So those were some
And
of the challenges that we faced.
okay. And so how many TB patients have benefited through this project, especially in this 6 months period that you've started?
Yeah, our active TB case finding started in April 2020, and we've had 2 quarters data now from April 2020 to September 2020. So for 6 months, we were able to screen a total of 234,513 individuals in the 15 BMUs of the 5 states, out of which 7% of them, that is 15,532, were presumptive TB cases. And out of these presumptive TB cases, we were able to refer 89% of them for diagnosis. Out of these 89% of them, we have been able to harvest 4% of them, that's 625, as bacteriological positive cases of TB, and we have also harvested 5% of them, that's 853 of them, as all forms. So if you look at the data for the 2 quarters for the 15 BMUs in total, you will see that our TB Reach Wave 6 scale-up grant has contributed within these 2 quarters 82% to their bacteriologically positive cases and 79% to all forms of notification.
Those are great figures. Thank you so much for sharing them with us, Dr. Valerie. So, what advice would you give our learning network members who set out on active case finding, especially during this COVID time? What advice would you give them?
During this COVID time, we faced a faceted barriers of services, both at the community and at the facility. Of course, you know that with the COVID, because of the limited awareness on COVID, there was fear in the communities, and the individuals in the communities were skeptical about receiving, people who come with TB services. And, collecting sputum became a difficult thing to them. Collecting sputum, they were scared that maybe we want to test for COVID-19, and then they will be taken to a facility and they will be, admitted in that facility. So we saw a lot of barriers in this area. And we also saw that most of the few medical personnel that were around in facilities were channeled to support COVID patients. We also saw that the bad models in gene expert machines and the cartridges had run out because of the lockdown and all the restrictions. It was not possible for them to be replaced immediately. And of course, like I said, unavailability of PPEs, we had to make sure that we provided our frontline health providers with PPEs. Therefore, in carrying out active TB case finding at a time like this, at a time of COVID, it became necessary that you liaise with your local health authorities. And that was what we did. We liaised with the local health authorities, and with that, we were able to apply health provide unrestricted movement in the different communities that they serve. We also, with the support of TB Reach, were able to channel some funds for the procurement of N95, of hand sanitizers, and of hand gloves, because the laboratory personnel were looking for all those things as well. And we were able to distribute them to all our frontline health providers. Also, we had to also do what we are doing now. We had to use Zoom. We brought in a resource person to train us, both the project staff and also the frontline health providers, using also Zoom to train them on COVID-19, continuing TB care during COVID-19 to allay the fears that was being seen. And we have also been able to augment the monetary support for our frontline health providers to support them at a time like this. So I think it is very important, if you want to carry activities during this time, to work closely with your TB program, with the TB program in your area, and also with the health authorities in your area.
Those are great suggestions, Dr. Valerie. Thank you so much. I completely agree. We are all in this together, and we have to work together to overcome this hurdle that's there. So thank you so much for taking the time once again to speak with us. It was a really pleasure hearing your experience, and I wish the team the best with the entire project.
Thank you very much. Before I end, I think it is very important that I also say a big thank you, especially to Stop TB Partnership and TB Reach for giving us this grant that has enabled us to find these cases. If without the grant, these cases would have maybe died of TB. And I also want to say thank you to the National TBL Control Program Coordinator in the person of Dr. Adebola Lawans, and she and her team have been of great and huge help to us. Let me also thank the program managers at the state level and the Ministry of Health at the 5 states that we are working in. Their support has made the work easier for us. And before I end, I would also like to thank our project team, particularly our executive director, Mr. Andy Ayo, who has given us a lot of support in this project, and also all the frontline health providers who did not mind the COVID-19 pandemic, but went to the field and ensured that they found cases, they screened cases, linked them up to diagnosis, as well as made sure that they continued their treatment by becoming treatment supporters themselves. And thank you to TBPPM Learning Network for giving us this opportunity to showcase our project. Thank you so much.
Thank you, Dr. Valerie.